Hello. Good morning, everybody. Thank you for joining me. I'm going to quickly share my presentation and we'll get going. All right, so my name is Wendy Davis and I'm joining you from Green Bay, and we're going to be talking this morning about improving clinic flow and daily functions. So a little bit about this session. Our learning objectives are going to be focused on learning about lean process improvement, also known as lean thinking. And at the end of the session, it is my goal to have you understand how these principles and methods are going to help you understand and identify waste within your operations, and then be able to get started practicing the Plan, Do, Study, Act approach to solving problems. One thing before we get started, if Kara hasn't already, she's going to put a message in the chat feature. If you would like to type in any questions that you have along the way, we'll be reserving time at the end of the session to answer those. So a little bit about where I work and where I'm calling from. I work for Prevea Health. We are situated we have two divisions within the state of Wisconsin, an Eastern and Western division, and we have over 45 clinic locations. So we span quite a big geography. We also have numerous employer-based clinics. So we have small clinic settings within local businesses, or it could be a freestanding clinic for a dedicated employer. We are a physician-led and managed organization, which speaks volumes to how we practice and how we make decisions. And we offer more than 60 specialties throughout our regions. We partner with HSHS hospital system throughout the state. That has been a long-standing partnership and a lot of cross-collaboration with that hospital team. A little bit about myself. So as I mentioned, my name is Wendy Davis. I have been with Prevea for almost 6 years. When I started at Prevea, that was my first step into a healthcare setting. Prior to that, I worked in higher education. So I worked at a university. Within both of these two organizations, I have been practicing process improvement using lean methodology for over 10 years. And I have a bachelor's in business management, and then I have a lean certification certificate as well. So like I said, I've been practicing for 10 years, and within both of these types of organizations, been focused on looking at operational and flow improvements. You might be thinking that healthcare and university setting are vastly different, and while that is the case, they are both service organizations. So we serve a person, and our workflows are very, very intricate and can vary a lot because there are individual needs. Whether it's a student or a patient, we have very individualized services, which is vastly different from a manufacturing or a product-based service. Okay, so here are the topics we're going to cover today. I'm going to start out with a baseline introduction to what lean methodology is and explain a little bit about that. From there, we're going to start talking about the 8 different types of waste with the goal of helping you identify and understand what waste looks like, so that when you go back to your work and your key processes, you're going to have a different eye and hopefully start to identify some of those opportunities to help improve your flow. And lastly, we're going to talk about the problem-solving process, so a specific method or approach, if you would, for how you would go about combating that waste that you identify. So the first one is the introduction to lean. So taking a step at a very broad, high level, lean is a approach or a mindset that you take when you're thinking about and looking at the work you do. So within lean practice, we're going to talk about the forms of waste. We're going to talk about steps you might take to follow a problem-solving process. There's a host of tools and approaches that you can take when you're applying lean. But at its foundation, lean is really about your mindset and the way you think about the work that you do. So I like to start with talking about the 3 Ps. So when we think about the work and the key processes that we carry out, each of those is going to have a purpose. So what value are you providing to your customers by carrying out that job that you do? So what is the purpose of that process and that work? Secondly, when we identify, what is the value of it, there is a series of activity, and we call them value streams. Value meaning a stream of activities that are providing value to a customer. So that process has flow, and there can be bottlenecks and things that impede the flow or waste within those processes. The third P is people. So approaching a process improvement philosophy, a lean philosophy, the mindset is that we need to engage the people who carry out the work to identify the improvements and sustain any changes. So the people who are closest to the work, that is a phrase you might hear when you start working with a process improvement approach. Those people who are closest to the work are the ones who are encountering the problems, they understand the bottlenecks and the issues, and they're going to be your best source to engage and identify some improvements. So in a nutshell, that philosophy is about a pursuit. And I'd like you to think about how powerful that word pursuit can be. A pursuit is a mission. It's a way of being that you are going to take to provide that value to your customers, identify waste, and to consume the fewest resources while utilizing the talents of the people who do the work. So that's what lean methodology for process improvement is at a philosophical level. And for the rest of the presentation, we're going to get down into some details of the application. So the first slide I have here are the 5 principles for lean thinking. So as you think about work, and this is where you're starting to think about a particular process or workflow that you have. And you're going to get down to that process level, and you're going to want to start defining what is the value. So remember when we talked about purpose on the last slide, there's a purpose for what you do, but each individual process is going to deliver a particular service or product to a customer. In a healthcare setting, those are typically patients. So what is the value that that customer or patient is receiving from that process? And a unique question to ask is, if they knew I was doing A, B, C, and D, and E to do this and get this service for them, would they be willing to pay for each of those incremental steps? And you can start asking that question when you get to that second principle of mapping the value stream. Now we say mapping the value stream because typically within process improvement, one of the tactics we use is to identify our work using, if you will, sticky notes up on a board or drawing a process flow on a flip chart sheet, whatever it be, that you want to be able to visualize and understand the activities. This is very important in service environments because so much of our work is invisible. So it is a documentation in a chart. It is an email. It is something that goes unseen to the naked eye. So mapping the value stream is a really great activity so that you identify all of those steps and activities that are needed in our current state to bring that product or service to our customer. When you get to that point of understanding, you're going to be able to start asking questions of whether each of those incremental steps are adding value. Are they wasteful? Is there anything within that workflow that is impeding the flow? So principle 3 is taking that value stream and ensuring that all of the activities are running smooth without interruption or delay. When we get to the point where we have a process that's running well, great flow, we can start to think about establishing pull. Pull, if you will, is ensuring that our processes are running with the intention that there is customer demand, so that we are not pushing work, products, services, or materials, that we are sending them at the point that they're needed and that demand is there. The final principle for lean thinking is the continuous pursuit of perfection. So as we go through the rest of the presentation, we start talking about waste you might be identifying and working through within your processes. Think of capturing that waste and working on it little by little. So small changes along the way versus a total one-time revamp of a particular process. Small changes daily will get you there in the long run, and versus a revamp that can take a lot of strenuous effort and time away from your day-to-day work. So a little bit about that pursuit. I have a quote here from our local legend, Vince Lombardi. "Perfection is not attainable, but if we chase it, we can catch excellence." And I really like that. I think that's what process improvement is all about, that we are always striving and pursuing to be better. So I'm going to take a little bit of a deeper dive right now. When we went through those 5 principles, I specifically called out principle 2 and 3, where you are defining the value stream and then making a determination as to whether each of those steps are adding value or not. I do have some definitions on the slide here that talk about what activity would be value added for our customers and which would be essentially waste. And going back to that question that I shared earlier, would our customer be willing to pay for this? So if you always bring back questioning each individual activity or step within your work as to what value it's bringing to your end customer, you're going to start answering some questions about how your processes might be set up. Sometimes we set things up or put things in place to make it easier for another individual, or we might identify that it's duplicative work. Those are things that are unnecessary for the customer to gain the value from that process, and we can work on those. Those steps are essentially non-value added. So any activity that's consuming our time or resources and not adding to the value. There are going to be steps within your process that don't add any value, but that are deemed necessary. Some examples from healthcare might be legal or regulatory items, forms that we need to fill out, documentation, that sort of thing. So as we think about our work and our processes, I'm hoping we got to the point where you might have a key process that you work on in your day-to-day that you're thinking about, oh, I wonder if I could improve this at all. I want you to think about that process, or maybe think of a process if you haven't already, because we're going to dive into what waste looks like. So those non-value added activities essentially are waste, and there are 8 different forms of waste, which we're going to cover next. So this section, this is our second component of our agenda today. We're going to talk about learning to see waste. So I mentioned there are 8 forms of waste, and within lean process improvement, I have a slide up here that shows those at a high level. They form a nice acronym called downtime. So downtime is representative of the 8 forms of waste, and we are going to walk through these one by one. So again, think of that process, or think of your work environment, and as we go through each of these forms of waste, I want you to think about if you encounter any of these, and maybe you'll even start thinking about ways you can counteract the waste. So let's go through them. So the first one is defects. Defects are pretty straightforward. It's a very common word. It's any work that you're doing or any effort that you do that is essentially caused by rework, scrap, or incorrect information. Each of these types of waste slides are going to go through common examples of what it looks like and causes. So some of the examples of defects, and I do have quite a few healthcare examples up here, are any retesting or re-imaging. So, you know, re-imaging, you didn't get the body part correct underneath there, so you have to take a second image, or there was incorrect information about what image was needed, so you had to do that re-image again. Recollection of lab work. Anytime there's something that was an error or done wrong, so whether it be on a form, a wrong medication or dose, or dissatisfied patients or customers, there's something that went wrong in that situation. So common causes of defects are, you know, do we really understand what our customer was seeking? So if they were coming in and they wanted to seek us for help in this area and we took them down another path, that's a defect. We're not meeting their needs. They're going to be dissatisfied and something went wrong. Other common causes are making sure that our training and visual aids are up to date so that the proper education can be in place so that those misses don't happen. Insufficient communication or lack of communication about a change that needs to take place. And then thinking about your work environment. So if you have a high stress or noisy environment, or you're particularly busy on a certain day, maybe it's Wednesdays are your busy day, and how can you free up or level load your week so that Wednesdays aren't so crazy? But situations and environments like that are prone to making more errors and defects within our work. The second waste is overproduction. So this is essentially producing something more than what is needed or before it is needed. So this might look like bringing extra or getting ahead, getting supplies ready just in case they're needed for an appointment. These are 2 very common examples that I've seen in our clinic environments, is that we have some clinics that will go as far as labeling the tubes for cervical cancer screenings and the equipment that's used, so it can go to pathology. So opening and getting those supplies ready only to have our patients decline their pap smear. So that just in case thinking or getting ahead can be overproduction and then cause that waste on the back end. So that is an example of a push environment that I just shared. So if you remember back to those 5 principles where we want to be able to have our processes achieve good flow so that we can get to a pull environment, so that when a patient agrees to their pap smear during their appointment, that they are going to have the supplies ready and be able to label the appropriate things and get that ready quickly during that time on demand. Other causes of overproduction: we don't trust our processes to produce on demand, and sometimes we're not focusing on that entire value stream. So I know my part of the step, but I don't really understand what so-and-so does next. So I might push that down the line, or I might not have things ready for them because we're siloed and we really don't understand what each other does. So getting together and really understanding how processes come together can really help improve flow and reduce some of these wastes that we're going to talk about. The third waste is waiting. Very common. I don't have to do much describing of what this looks like. We've all experienced it. So anytime that there is wasted time when we're waiting for somebody, something, or equipment, this is not necessarily always a person waiting. So in what it looks like, so we have patients waiting in exam rooms. Patient might be at home waiting for a call with an update on their results. It might be staff members who are idle that are waiting for their next work to come. One I always like to point out is when there is equipment halted. So a nice example I have of this is we had a imaging machine that was only being utilized at 50% of its available time. The reason being is we did not have a changing room for our patients to change down into the gown in order to go within the equipment, so they had to change in the room with the equipment. We identified that if we had to move another department out, but we were able to free up space to create a changing room, which doubled the amount of imaging that that piece of equipment could do in a given day. So it opened up capacity for our patients, and our staff were working. They didn't have those times that they were being idle where the equipment was being idle. It was a win-win. So common causes of waiting are handoffs and approvals. So have you ever had something that you were ready to get started on, but you needed to wait for an approval? We're going to talk about handoffs and approvals a little later, and I'll save my example. A push environment. So if you're pushing things and then you're left and you're waiting, or maybe that work is pushed onto the next person and it's just sitting in queue because they don't have time to work on it. That's an example of where a push environment and an unbalanced workload pans out. So worker A can get their work done and hand it off, where worker B is the receiver of that work to do their part, but they take much longer and they can't get work moving down the flow fast enough. So that's where you need to start thinking about how balanced is the handoff within your processes and your staff, and balance that workload. Long process setup times can also cause wait. So the fourth waste is non-utilized talent, and this is really about thinking of us as individuals. So are we tapping into each of the folks on our team, their talent, their skills, their abilities? So this might look like not engaging those to get ideas, not involving people in conversations when we're starting to talk about, improvements or ideas, and they might be a best source because they work closest to the work. This might look like somebody working well below their skill level, where they have the skills, the knowledge, and the ability to work at a greater level, but they're essentially stuck doing things below that level. And then excessive handoffs, reviews, and approvals. So this is where I want to talk about that example I mentioned earlier with waiting, is handoffs and approvals. So this comes down to that letting go, letting others do, and trust in the workforce. So handoffs and approvals, although many times very necessary, are oftentimes one of the largest inhibitors of things getting our processes and work continuing, because they can take a really long time. Typically, reviews and handoffs need to go up throughout the organization, and those members in those roles they're not as free and have that capacity to sign off and review all of those things in a timely manner. So one example I'd like to share is there was a committee that we had set up that would make decisions on work, and that committee would come together, they'd evaluate work, they'd reach a decision, and they'd send that up to our department chair. And then that department chair would sit on it and sit on it and sit on it, because he needed a lot of time to actually read through their analysis and recommendations. And it would delay that work from starting for many, many weeks. When we looked into it, what we found is that there was not one time in the history of that review process that that department chair disagreed with the committee. So upon sharing that with them, it was kind of like this aha, what is my review and approval even doing? Maybe it's a need to know and an FYI, but it was that approval necessary. So it really got down to thinking about that and allowed that work to happen a lot quicker. Transportation is next, and that is the unnecessary movement of things. So movement of products and materials, very straightforward. Carrying things around, rearranging things, tangible supplies, equipment, and your physical work surroundings. So common causes of this unnecessary movement are considering the layout of your operations, layout of where you keep your storage of necessary supplies and inventory, and then lack of having that supplies and inventory where it's needed. So, you know, walking around looking for a piece of equipment, where could you have one in each of your exam rooms, that sort of thing. Inventory is essentially what it sounds like. It's excess supplies, excess products and materials that are not being currently utilized. So I think we're all guilty of this in one way or another in one area of our lives, but the stockpiling of supplies, materials, information, or forms, essentially it can be expired or out of date information and can result in disorganized storage areas. Common causes of this are just in case thinking, I ran out of that one time, I'm never going to run out of that again, so I'm going to order triple of what I need, and then it expires on the shelf. Unreliable purchasing schedules. So if you're not working well with your supply chain, and you don't have that trust and the reliability of that delivery, that you're ordering up and stocking up to because of that concern. Motion, very close to the transportation waste, is the unnecessary movement of people. So what it looks like is traveling to shared equipment or spaces, people looking for information supplies. It can also be within your individualized work environment when you're sitting at your desk. So if there's any far reaching, think about repetitive keystrokes or clicks within your documentation processes, that sort of thing. Can get down to that very fine-tuned unnecessary motions that we do. So common causes of motion are, again, looking at that layout and then the ergonomics of our personal space and our personal workspace. So I have an image up here of a tool that we use in process improvement when we have concerns about motion or transportation, and that is looking at a bird's eye view of a workspace and then tracking the staff time and time again throughout the process to kind of see where things are going. So it looks like this A bay right here, you know, sometimes staff need to go here. They don't need to do it for every time of the process. So what is over here that's causing us to go here? This probably of a, you know, maybe 25% of the time they have to go over here. Can we move that closer to their work? Extra processing is our last form of waste, and it is more or higher quality than is required by the customer. So unnecessary procedures or testing, unnecessary amount of detail. So, you know, you know, I only need an X-ray, but an MRI is ordered. It could be redundancies or duplicative data entry, work that goes unused or unneeded. So this is common causes are not understanding what our customer wants. Process not updated is probably the most common. So you're doing all that extra work because it was necessary in the past, but things changed. Maybe the training wasn't updated or good communication didn't get out. So you continue to do it, but it's not necessary anymore. So you're doing that extra work, that extra processing. Sometimes it could be a personal trust issue. So you don't trust a source of information. So you go and look for it yourself, or you do it over, that sort of thing. Okay. So that covers the 8 forms of waste. And I want to leave you with this quote. So even though we've talked about those 8 forms of waste, what they look like, common causes, I want you to remember that if you identify a waste, the first thing you should do, rather than trying to streamline it and make things flow better, is to consider whether it needs to be done at all. So there's nothing more useless than doing something efficiently than doing something that which should not be done at all. So really thinking back to that purpose of your process and if it's even necessary. If it is necessary and there's a purpose and a value, then let's look at how we can make it run a little bit smoother, remove the waste, and do it more efficiently. Okay. All right. So we are merging into the last component of our agenda today, and that is starting to talk about the problem-solving process. So when you go back and you start thinking about your work, and applying those 5 principles, where you're starting to think of what is the purpose of my work, how does it flow, what wastes am I identifying within that value stream of activities I'm carrying out. The problem-solving process is a method that you can apply to solve a problem or to work through that waste. So the problem-solving process is also known as PDSA, and it stands for Plan, Do, Study, Act. And that PDSA, Plan, Do, Study, Act, are each of the 4 incremental steps that you're going to work through to tackle a problem or waste that you identify. So it's important to know that PDSA is a very methodological approach. So many of us in our traditional practices, myself included, it does take effort to really focus in and do a good PDSA process. Because as humans, we identify a waste and we say, oh, I have a great idea. And we go from planning to acting. So we say, I have this great idea, I'm gonna do it, and I'm gonna put it into action. PDSA is really going about that idea phase and really understanding, what am I trying to achieve? Here are my ideas. Are they going to work? So it's that hypothesis, experiment, and evaluate, that scientific method process that you used in middle school, high school science and chemistry classes. So you're making a hypothesis. So whenever you identify waste, you're going to say, oh, I think this is going to counteract it. That's your hypothesis. And rather than just putting that in place and acting, the PDSA methodology is really going to help you hone in and say, let's trial this, let's experiment with it and evaluate its impact. So PDSA really focuses on that learning through experimentation and using evidence-based decisions and critical thinking to say, this worked or this did not work. So we're going to dig a little bit deeper about what PDSA might look like and talk about some of the specifics of each of the steps. I have some examples that I'm going to share on the next slide. But what essentially happens in plan is you want to have some baseline data. So for example, 50% of the time we carry out this process, this is missing. So if you know that you have a problem or you identify a waste, try to capture some data on how often it's happening, where is it happening, and just get some good understanding of, where in the process it's happening, and some baseline data. From that data, when you say, oh, this happens 20% of the time, 30% of the time, you want to set a goal. So a goal might just be, we want to improve it, we want to eliminate the problem, whatever it is. The other thing about PDSA is you might not have a specific problem that you identify, but in the pursuit of perfection, you want to get better. So maybe you have a quality measure that is great, and you have 70% of your female patients who've had their cervical cancer screening, but you just want to improve that. So you could set a goal. From there, you could identify some causes or reasons why some of your patients aren't getting that screening done and counteract it. So whether it's a problem or a desired state, each of them are going to have a gap. And it's that baseline data that you really want to understand so that you can help track and measure that you're making progress. The plan is also going to encompass really understanding what's going on or where you want to be, identifying what's preventing you, so whether it's waste or other issues that are preventing you from getting there, and planning how you're going to counteract that. So that might be a brainstorming session where you're going to think of ideas to counteract the issue. So for example, say you have 40% of your patients not scheduling an appointment upon their departure. An experimentation might be, let's have that scheduling representative change their physical location so that so instead of having a side profile to the patient leaving, they move their desk and surroundings and they can make eye contact with the patient on the way out and have a conversation. So that might be something that you could say that could improve the scheduling appointments upon discharge, and I'm going to trial that out. I think that's going to increase my schedulings. Maybe we'll reduce it to only 20% of our patients not scheduling upon departure. So essentially you're making a plan and experimenting and have an idea in place that you want to trial. The do and study is when you put that in place, you make those changes, and then you measure the impact and make decisions about what you learned. So did something work well? Maybe it didn't pan out. Maybe you didn't see the benefits or improvements that you were thinking you'd see. Maybe you need to tweak it. Maybe you need to add to it. Maybe you need to try something else completely. So this is the part that we often miss when we are in that kind of that human nature to just go from plan to act, this do and study. I do recommend that you do this on a small scale. So whether that be, with one small work team, pilot it in a small area and test it out. Sometimes we're fairly certain that these things are going to work. We can almost guarantee at the plan stage that it's going to make an improvement. The thing about the do and study is there's always, always, always learnings. So whether you're putting a new process in place and changing things around, you're gonna maybe hone in on the best scripting or the best way to, maybe there's some signage that you put out at that desk. You're gonna identify and learn about those small little tweaks and changes that you can do during that do and study phase. So I highly recommend that you take some of these components of the PDSA methodology and really hone in on that do and study when you have an idea that you'd like to test out. So whether you know it's going to be successful or not, you can learn about those small tweaks that need to be made on a small scale before you then roll it out to your entire organization or your entire department. That rollout is what we call ACT in the PDSA methodology. It's really where you determine that the plan was successful and you are going to adopt it as your new standard. So you're going to document it and you're going to implement it and monitor it. I do have some examples. So I shared one about the checkout desk situation. A couple other PDSA examples that I have here up on the slide, and I'm going to walk through them. A 9% error rate when administering medications. So that's a pretty high error rate. And to counteract it, they were going to trial and study the impact of a double check process. So we're going to double check for expiration date. We're going to have our nurse double check that, you know, it's the right medication at the right time for that patient, that sort of thing. And that was their plan and their do in their study. They were going to see if that double check process worked. The second example is more of a pursuit of doing better. So you're already seeing 16 patients per day, but you want a goal of reaching 18 patients. So this is really thinking about what can I look at, what data should I collect that's part of my daily work routine. Do I have certain parts of my process that aren't adding any value to these appointments that I can reduce? Maybe if I could eliminate some of those things that don't add value, I can shorten my visit lengths. Do you have any certain things that happen throughout your day that you're waiting on equipment, supplies, and information, and that's built in? So really thinking about understanding that current state of what's going on in those value streams to say, how can I streamline it and improve it? The last bullet I have on here is a question, water droplets on a penny. So when there was the thought that this would be an in-person training session many, many months ago, I was hoping to do a very fun hands-on PDSA experimentation process with you, and I just kind of wanted to talk through that. If you think about a pipette of water, so a little tube of water, and then a penny, the experiment was asking our attendees to make a hypothesis of how many drops of water could fit on the surface of that penny before it spills over. Now I have done this. I want you to think about that in your head right now, maybe grasp onto a number. I have done this experiment before, and typical hypothesis just from that question are relatively low. I would say anywhere between 5 drops of water to 20 drops of water is that initial hypothesis. And then I have the teams actually go and experiment. So do a do and a study and see how many drops of water can fit on that penny's surface. And they are beyond surprised when, you know, they're hitting 20, 30 drops of water on that penny before it spills over. So from there, to replicate that PDSA process, we have them identify changes that they can make to dropping the water on the penny. So whether they're going to hold the pipette up high and drop the water straight down, is the tail side going to hold more water than the head side? Maybe a new penny with a higher ledge around the outside is going to take more drops of water than a penny from 1954 that's been smoothed over. So they start thinking of different ways that they could make a change to improve the number of droplets that fit on the penny. And they run through a series of experiments. So I have them go through that process many times, 3 to 4 times. And our highest number of drops of water on a penny to date has been 68 drops of water. So just some learnings that they have, that they come. So they might say, I'm going to drop it high, or I'm going to drop it low. And what they learn is, I thought it was going to give me more drops on the penny, but I had less. So it's really honing in on that study and learning through that experimentation phase of the importance of the PDSA methodology. And just because I'm sure you're curious, the most effective method is to hold the pipette at almost a 30-degree mark from the penny and drop the water from there. When the pipette is held at that angle, the water droplets are a lot smaller. So I just have 2 more slides left, and I'm going to try and get them quickly through here so that we can have some questions at the end. As you're taking those decisions, so once you go through the the study and you determine that this is the new way we're going to work this process because it worked out, we made improvements, I do want you to think about developing those decisions as standards for your work. So standards have varying levels of components. So a standard might be a decision that you make, a clear determination of what we're going to do. Standard work is going to be the detail level of the information that's needed for each of the individuals that are going to carry out the standard. And then the standardization is the practice of communicating that standards and the standard work and then continuing to improve it. I do have one example to kind of show you how detailed this can get. I'm hoping that many of you are familiar with the JNC8 guideline and algorithm for hypertension. It's an algorithm that basically determines, based off of a patient's age and maybe some demographic information, what their normal blood pressure range is. So this is a guideline that's put out. It's a practice standard within our organization. However, what we noticed at Prevea was that we had some providers who had great blood pressure control within their hypertensive patients, while other providers did not. So we were saying they're both following this. They're both following the recommendations for medication and all of that. Why is one provider outperforming another? And what it came down to is there was no clear standard work developed to adhere to the standard. So if we have the standard, we know when a patient comes in and has a high blood pressure or not. However, what is our next steps? So if a patient's blood pressure is elevated, when should we have them come back? What if they're being seen in our orthopedics department and not by a provider that's managing their hypertension? What do we do then? So those situational components is where we needed to develop standard work to allow those workers to say, when you encounter this, this is what you should do. This is the recommendation for getting that patient back in. So here's some examples of our standard work. Probably one of the largest impactors to this was taking that second blood pressure reading in the appointment. Many times our patients have elevated blood pressure at the beginning, though after they speak with the provider, and then at the end it's lowered. And then we have a recommendation for timeline for returning. And here's an example. Once we put those standards in place, tested them out at a site, and then we tweaked them and rolled them out clinic-wide, you can see our hypertension control rates on the upcline here in this graphic. So that was the act of standardization, taking that standard, building standard work so that people know what to do, and then rolling that out and communicating that so it is practiced. All right, so we've talked about the 5 principles of lean thinking and how you should approach and set your mind to start thinking about your work. We went through the 8 forms of waste, where you can start looking at processes and thinking about waste that you identify within them. And then we went through the PDSA process to talk about how you might approach those waste and that issues that you find within your work processes. focusing in on that experimentation and study component so that we understand if changes we identify to make are actually gaining us that improvement that we sought. So that is all of the content I had today. So we have just over 10 minutes for any questions. I'm going to stop sharing my screen, and Kara and I will be available.
Okay. Thank you, Wendy, for that great presentation. Can you hear me, Wendy? Can you give me a nod if you can hear me okay?
Yes.
I'm doing great. Okay, sorry, I was getting an internet message. So far, no questions in the chat, so please feel free if you have anything. And well, people are thinking, my name is Kara Bergronick, and I'm the Director of Clinical Quality for HCET, so thank you for joining us today. I have a question, Wendy, while we're waiting for people. I was wondering about, you talked about getting people who are close to the processes to have the opportunity to give feedback and participate in the process. Often that's really difficult when those are the people providing clinical care, that taking someone out of staffing is a big inefficiency, right? So how do we create room for the people on the ground to be able to participate in this process?
That's a very good question. Probably been the most difficult one that I faced. So coming from higher education, working at a university, we had that luxury of pulling people away from their work, and moving into the clinical setting, that's not the case. The minute you pull people away, work stops. Patients can't get in, and you know, that revenue stream is lost. So it has been a difficult transition. However, what I found is that I've worked with our supervisor, or you know, maybe the manager of a clinic, and work with those key roles where they may have a little bit more flexibility to be able to dedicate time to meetings, and asking them to round. So round while the work is happening, and just gain that in the moment feedback so they can capture it from there. Once you get that feedback, that's where you're going to really understand what's going on. You can start to develop an understanding of what the problem is and get some of that level of detail needed so that you can have a much shorter duration when you stop the line, if you will, and pull people away to think about changes and improvements. You do need to have time for that. We do a lot of 7 a.m. meetings here at Prevea, so before clinic starts. I've come a long ways, and I can get a lot done in 2 hours or 1 hour with a group of people. You just have to have your data, your understanding, and be prepared to start having those conversations quickly, and you can make it work. Very good question. It is a lot more difficult in patient care environment.
And I suppose a follow-up to that, what are your best suggestions for getting buy-in from the folks on the ground? So even though there was rounding, it's a level removed, how do you make them know that their voices were heard so that they're on board as changes, especially because sort of a lean model can feel like more with less. We're all getting used to hearing that. How do you bring people along?
I have found that as long as you're upfront and honest, and you take, if they provide a idea, that you don't dismiss it, that it's the frontline staff who are very willing. I have found that I struggle with buy-in typically more from a leader or a high-level stakeholder of a process, or perhaps when a process might be, you know, lending itself to being easier for person A and tough on person B, that person A might be more difficult to gain buy-in. The largest component for buy-in is always bringing it back to that end customer. So bringing it back to the patient or the customer at the end of the process, and showing with data, if you can. Data is black and white, and it's hard to be challenged. It's hard to challenge hard data, that, you know, something is just not working and not meeting the needs. So if you can have data and you can bring it back to that end customer, the process stakeholders usually come together.
Thank you. Anyone else, feel free to use the chat or the Q&A feature, whatever is better for you.
Are there any particular questions or processes that you had in mind during the presentation? Just want to share specific questions. Okay. Well, I will give that 60 seconds. That's another strategy. 60 seconds. It takes a long time to wait, but if there's a question lingering, it will come out in 60 seconds. That's another facilitation tactic when you're trying, if you ask a question to try and get people involved, waiting that lengthy 60 seconds for a response. People will generally start chiming in if they have a question or an idea. But if there are none, I can flip it over to my contact information, and I'm happy to work with anybody if they have specific questions offline. Otherwise, those can be shared, and we can get responses out to the group as well.
Thank you so much, Wendy.
Thank you. All right. And there is my contact information. Thank you for having me today. Enjoy the rest of your conference.